Here.
Okay, so welcome everyone. It is my pleasure to introduce Dr. Aggarwal, who is a professor of medicine at the University of Pittsburgh and medical director of Arthritis and Autoimmunity Center at the University of Pittsburgh Medical Center. He's the co-director of UPMC Myositis Center. His research and clinical areas of interest are clinical and translational research in inflammatory muscle diseases, myositis, and associated interstitial lung disease. He is the past chair of the Medical Advisory Board of the Myositis Association, as well as past chair of the Scientific Committee of IMCAS, which are the largest patient and physician groups working in the field of myositis, respectively. Dr. Aggarwal is an established independent clinical investigator with significant funding from NIH, foundations and industry, and currently leading several collaborations internationally with other key leaders in the world. He has maintained an extremely high publication record and received national and international recognition for his work. He continues to be a leader in disease criteria and outcome measures in myositis, as well as in clinical trials of novel therapeutic agents for myositis. He is currently the principal investigator or member of the steering committee for several international phase 2 and 3 clinical trials in the area of myositis and associated ILD. Dr. Aggarwal is also mentoring future generations of rheumatologists with great success and attracting younger rheumatologists towards myositis research for the advancement of the field. Dr. Aggarwal lectures at various international conferences and promotes patient education through his YouTube channel. So without further ado, over to you, Dr. Aggarwal.
Well, thanks a lot for inviting me to present this talk at Global Dermatology Talks. And I believe most of the audience here is dermatologists, so many of you obviously know dermatomyositis probably somewhat better than me in terms of the rash at least. So we'll dive into it right away. And the topic today is IVIG, the role of IVIG in dermatomyositis. So first, just as a background, I want to talk about what myositis is. We call it as idiopathic inflammatory myopathies, or IIM, or in short, we call it myositis. It's a rare, heterogeneous, systemic autoimmune disease with primary target of muscle and or skin. And it traditionally had 6 clinical subsets. We used to divide it into adult polymyositis, adult dermatomyositis, juvenile myositis, which is also mostly juvenile dermatomyositis, cancer-associated myositis, which is also mostly cancer-associated dermatomyositis, connective tissue disease associated myositis, or in other words, overlap myositis, and inclusion body myositis. So today's topic is dermatomyositis. So I also want to emphasize that in last decade or two, we have recognized a distinct clinical phenotype called CADM, or clinically amyopathic dermatomyositis. And there are many reasons that we actually don't want to lump this category into the overall category of dermatomyositis. And main reason is they're phenotypically very different, their prognosis is different, and their treatment outcomes are also very different. So we want to respect that entity of CADM and sort of move it out of the overall adult classic dermatomyositis. In terms of epidemiology of myositis, it's common more in females than males. And about 2/3 of patients are females as compared to males. And the incidence is around 1.1 per 100,000 and prevalence of about 13 per 100,000, at least in US. This data is from US. But I wanted to emphasize here, at least see how the frequency between male and female of incidence and prevalence changes by the age group. As you can see on the slide, the light dots are males and light blue dots are males and dark blue dots are female. And you see they start out to be the equal frequency around early, around 20 to 40 years. But then as they age, the frequency continues to increase in female and not so much in male. We don't really know exactly the reasons, but at least some aspect of hormonal changes might also play a role here. Now, another thing I always, when I lecture, I tell people, students, residents, and doctors that myositis, don't think about myositis as only muscle and skin disease, although most commonly it presents with muscle and skin disease. But if you ignore other organs involvement, then you could, one, miss cases and also would not be able to treat the patient in entirely. For example, many patients have interstitial lung disease. So we need to keep in mind and ask our patients about dyspnea and cough on every visit. And if we suspect anything, to get a CT scan or PFTs. Similarly, some patients present with arthritis. And if that's the case, sometimes I've made a mistake of diagnosing patient with rheumatoid arthritis before I recognize this patient actually has myositis. They commonly have Raynaud's, nail fold capillary abnormality, and they have proximal dysphagia, which again, if you don't ask the patient, they're not going to give that history to you because they don't know if that's related or not, if that they're having little difficulty in swallowing. And also perhaps the most difficult and challenging part of the disease is calcinosis. As dermatologists, you all know that very well, how difficult and painful and problematic it could be for the patients. These are some classic rashes of dermatomyositis, and I assume all of you are very well versed in this as a dermatologist, but for the sake of lecture, I'd like to go through it. So on the top left panel, you see Gottron papules, classic Gottron papules. Now, in the eyes of a trained rheumatologist or a dermatologist, it is very difficult to mistake something for a classic Gottron papule. But also remember, Gottron papule and sign can reside in elbows and knees and hide there very well. So please take a look at the elbows and knees. They can also lead to lupus-like malar rash. And this is where I feel we need to educate our medical community a little bit more. We recognize, as soon as I say malar rash, everybody thinks of lupus. Malar rash is classically present in dermatomyositis. And there is only one subtle difference between a malar rash of lupus and a malar rash of dermatomyositis, which basically is sparing of nasolabial fold. You see in this picture in the middle, there is no sparing of nasolabial fold, which is what you will see in dermatomyositis. And if in a lupus patient, there will be a sparing of nasolabial fold. Also, upper chest rash called V sign and shawl rash, which is on the upper back, is seen here. And a heliotrope, a rash on the eyelids, is also quite visible here. Also, make sure you also undress the patient and check their upper lateral area of thigh, because sometimes a holster sign could hide there, and also upper arm can have a rash as well. And rarely patients with dermatomyositis can get vasculitic lesions, ulcerations, and vasculitis kind of picture as well, as shown on one of the images on the left in the middle here. Nail fold capillary abnormalities is quite common in dermatomyositis. In fact, the only other disease where you can see such a severe nail fold capillary abnormalities that you could see the nail folds almost without needing any instrument or dermatoscope or stuff is scleroderma. So scleroderma and dermatomyositis are sort of the leaders in causing the nail fold capillary abnormality. So when the patient walks in your clinic with significant nail fold capillary abnormality, please think of dermatomyositis as well. Dermatomyositis currently poses significant problems in health-related quality of life. And this is just an image that I'm showing you, which basically compared the Swedish general population SF36 scores in 8 domains, and also PMDM in terms of their domain scores. And you see, regardless of the domain, PM and DM patients do far worse in their health-related quality of life. And this is a significant problem that we need to tackle in subsequent years. In terms of cost, overall management of PM and DM is multiple folds higher than any non-DM PM control patients. If you match them with not healthy controls, but non-DM and PM diseases, you will see that DM and PM would have a much higher number of medical visits, prescriptions, dermatologist visit, rheumatologist visit, inpatient admission, you name it, and almost every time you will see that there is significantly higher healthcare utilization in these patient population, partly due to the lack of excellent treatments available. But quality of life and cost is one thing, but mortality is a major problem as well. There is threefold excess of mortality in dermatomyositis as compared to general population. And so this is not just quality of life issue, this is also a survival issue. But up until now, I mean, there was no FDA approved therapies. The two FDA approved therapies that were granted FDA approval was in 1950s. There was steroid and ACTH. And they were not obviously proven because they grandfathered the approval process at that point. But we don't want to use steroid and ACTH so much in our patient population because it causes significant side effects. I mean, I think when I give steroid for long-term and higher doses to my patients, I'm almost trading off their disease. I'm maybe making their dermatomyositis better, but I'm giving them some other disease, including diabetes, muscle atrophy, osteoporosis, cardiovascular disease, and so on. So how do we used to treat? This is just my way of treating patients before IVIG trial that I will talk subsequently. We used to give high doses of steroid, followed by first line as methotrexate or azathioprine, followed by second line as a combination agent and mycophenolate or tacrolimus also as a second line. Third line, we used to use rituximab. Sometimes we use cyclophosphamide for ILD. And then we have many experimental agents that we used to use it. IVIG, we used to use either during the first, second, or third line whenever we need help. And almost every time we use IVIG, it provides significant help to us in first, second, and third line treatment. But we were not using IVIG as upfront, and it was used to be most commonly used as a second line adjuvant therapy. Also, just for the sake of completion, I want to also emphasize these sidebars, which are showing you exercise panel, are mainly shown to educate everybody that exercise is key to treatment in dermatomyositis, specifically when their muscle is involved, and exercise is somewhat anti-inflammatory for muscle. So what's the preliminary evidence for IVIG? Well, there are two major clinical trials. The first one by Delakas et al. In 1993, this was published in NEJM. In this trial, what they did, they took 15 patients who were previously refractory to treatment, 15 refractory dermatomyositis patients who were previously refractory to at least 2 drugs, including steroid. And they gave half the patient IVIG for 3 months, and then half the patient placebo for 3 months. And then they switched the patients. So it was a crossover study. And then those patients got IVIG, then got placebo, and those who got placebo then got IVIG. But if you look at overall, 63% patients improved on IVIG, but no patient really improved on placebo. But then that study was one clearly positive study, but then it was met with a negative study, which was a mixed population. That's why doing a mixed population study can be sometimes problematic. But in this study, they did 16 patients with dermatomyositis and polymyositis. And they also did a crossover study, but only for 8 weeks this time. And what they observed is no difference in MMT or CK in either population, or either patients with IVIG or placebo. So it was a negative study. So we had one good positive study, one study with some problems, but it was a negative study. That led to the major clinical trial that we started in 2016-17. This was an efficacy and safety of Octagam or IVIG, 10% in patients with active dermatomyositis. So most of my talk will be based on this trial subsequently. So let's look at the design of this study. It was a prospective parallel group, double-blind, randomized placebo-controlled, multi-center phase 3 study. What we did in this study is we screened the patient, 95 patients were screened, and were randomized 1:1 to either receiving IVIG at 2 grams per kilogram every 4 weeks, or receiving placebo at the same dose every 4 weeks as well. And it was the first period was a double-blind period for 16 weeks. At 16 weeks, we evaluated the primary endpoint. However, if the patient deteriorated during the first 16 weeks and the deterioration was confirmed, that's why you have a CD there, confirmed deterioration, then those patients could be switched to placebo versus IVIG. At 16 weeks, everybody went into an open label extension of 2 grams per kilogram every 4-week dosing. And again, when you're in open label, if you deteriorate, you could be excluded from the study. But at 28 weeks, a dose reduction of IVIG to 1 gram per kilogram was allowed. And this was at 24 weeks. So total period of the study was 40 weeks, 40. What was the inclusion criteria? We used Bowen and Peter inclusion criteria because at that point, we did not have a new classification criteria, which is 2017 EULAR-ACR classification criteria for dermatomyositis. Those who have not seen that classification criteria should definitely review that. But Bowen and Peter works fine for dermatomyositis, primarily because of the specificity of the rash of Gottron papule, sign, and heliotrope rash. Then we also determine if the patient truly has active disease. This was done based on expert consensus. That means an expert panel of dermatologists, rheumatologists, neurologists got together and said, okay, we review this case, and based on the findings reported by the investigator, this seems to be an active disease. Third, a patient had to have a refractory disease. That means they either had currently or previously failed or intolerant to standard immune suppression. And fourth, they had to have muscle weakness. So if somebody only had rash but no muscle weakness, those patients were not allowed in the study. And they had to have a muscle weakness by MMT-8 score of less than 142 by 150. So what was the primary endpoint? Primary endpoint, I told you, was at 16 weeks. But the primary endpoint was something called total improvement score, or TIS, which is based on 6 measures in myositis. And these 6 measures are MMT, which is manual muscle testing, which is muscle strength testing, muscle enzyme, then extramuscular global disease activity, which is where the rash get evaluated in this extramuscular disease activity, health assessment questionnaire, physician global disease activity, which is on a scale of 0 to 10, how active is the disease as per the physician, and patient global disease activity, which is also on a scale of 0 to 10, how active is the patient, is the disease as per the patient. And this score is spread out between 0 to 100 points. And if you achieve more than 20 points, that's a minimal improvement. If you achieve more than 40 points, that's a moderate improvement. And if you achieve more than 60 points, that's a major improvement. So this criteria was applied at week 16 and subsequent weeks to see how many patients improve. So let's get into the results now. First of all, the patient population I want to talk about. All patients in this cohort of 95 patients had proximal muscle weakness and typical DM rashes, which includes Gottron papule, heliotrope rash, and Gottron sign. Most of them met definite criteria by Bowen and Peter for diagnosis, and most of them were Caucasians, 75% females, and 53 years of age was the median age. Now, we did randomize 47 patients to receive IVIG and 48 patients to receive placebo. And first period, which is the 16-week, 95% patients completed the study. And then they were moved into an open label, and 72% overall, they had also completed the study. So there was very little dropout rate, at least in the first phase of the study. So what were the results? The primary endpoint, as we discussed, was minimal improvement of TIS of more than 20 points, which is saying, okay, clearly patient is improved, but it's a mild improvement. And in IVIG group, which is the Octagam 10%, 78.7% achieved that outcome, as compared to placebo, where only 43.7% achieved that outcome. This was almost doubling of the effect, with a delta of 35% and a p-value which was highly statistically significant. So it was clearly a positive study by significant magnitude. However, for me personally, minimal improvement is very low bar, and it's basically gets the patient started, clearly improves the patient, but it's not enough. So for me personally, to tell whether the drug works or not work, I would like to look at the moderate improvement, because achieving moderate improvement within 16 weeks in dermatomyositis patient isn't that easy. So the next slide, this is a slide I want to show where I think this is, if somebody asked me how many % patients improve on IVIG, my answer would be based on the trial, 68% would improve on IVIG, which is about 2/3 patient, which is similar to my clinical experience as well. So here you see the moderate improvement, which required more than 40 points on total improvement score. You have a 68% improvement versus 22.9% improvement. Now you have a threefold increase from placebo with delta of 45%, which is highly statistically significant values. But then you look at the major improvement, it drops off at 32%, but now 32% is also fourfold improvement from placebo frequency with a delta of 23%. I want to also remind people, major improvement in 16 weeks is quite difficult to achieve in dermatomyositis. Yeah, subsequently by 6 months or a year, yes, for sure. But you need a lot of improvement to achieve major improvement, and you have a very short time to show that improvement. So this is a graph. Now, I told you the total improvement score is a score of 0 to 100. So it can be spread out as a continuous score. So this is a graph where you're seeing total mean total improvement score on y-axis and weeks in on x-axis. And the blue dotted line represents IVIG, and gray dotted line represents the placebo. So you see from very early on, as early as 4 and 8 weeks, they start to separate out and continues to separate out until 16 weeks. But then when patients who initially receive placebo, they get IVIG, how quickly do they improve? And if you look at the slopes of improvement in the first phase and the slope of improvement in patients who initially got placebo and then got IVIG is identical. And they continue to improve up until 28 weeks. So that's another point I always make, that patients can continue to improve on IVIG for at least 6 to 8 months. And then they kind of plateau. So you don't see any further major improvement after that. So that's a total improvement score. So that is the primary endpoint. It tells you that the patient improved overall. But the main question I get asked is, okay, tell me what aspects of patient, what in the patient improve? Did their muscle improve? Did their fatigue improve? Did their muscle enzyme improve? Did their skin improve? And this is a graph where we are trying to show what aspects of the disease improved on IVIG. So you see the first one is extramuscular global disease activity, which is where your skin component comes from, and that halved in patients who receive IVIG as compared to placebo with statistically significant result. And if you look at manual muscle testing or muscle strength, you see the same results. Almost every parameter, including CDASI, for those who may not know what the CDASI is. CDASI is cutaneous dermatomyositis activity and severity index, similar to what we do in lupus, which is called CLASI. It's a scoring system developed by dermatologist Dr. Vicky Worth, where you give scores to each rash and you add up all the scores to see the overall active rash burden of the patient. And I'm very happy to report that if you look at overall, the mean score was 19 in IVIG group, and it's halved by the 16 week, whereas in placebo group, it didn't change that much. What about quality of life? We talked about that the quality of life is severely compromised in patients with dermatomyositis. And again, in this graph, what I've shown you is a 2 summary score, which is mental health score and physical health score, and 8 domains of SF36 that was evaluated in these patient population. And you see patients, the green bars are placebo and blue bars are IVIG. And you can clearly see that almost all domains improved. But what domain improved the most is physical functioning domain. As you can see on the graph here, it clearly improved by 2 to 3 folds while receiving IVIG and was statistically significant. Now, going back to the CDASI, I want to show you the CDASI graphs a little bit more, because now what we did here is we divided the CDASI in 2 different groups. One is the CDASI baseline score of more than 14, which basically means a lot of skin disease, at least moderate to severe skin disease. And you see how nicely these 2 graphs separate out. in the first go, where in the placebo patient, which is in the green dots and line, there's not much of a change, but the blue dots and line quickly decrease in the first 16 weeks. And then when the green dots and line gets IVIG at 16 weeks to 40 weeks, they improve quite as well. Again, proving that the patient with severe skin disease clearly would improve in this situation. But also, if you look at the patient with milder skin disease, which is less than CDASI of less than 14, obviously you don't see those robust differences that you see with higher score for the reasons from statistical standpoint, but you still see quite a lot of difference even with milder skin disease patients also improves in this patient when you give IVIG. Okay, so let's take a move towards safety and tolerability. So at least I hope we have proven with this trial that clearly it improves the strength, it improves the skin, it improves the quality of life, and so on. But what are the safety and tolerability problems? So first of all, I wanted to tell you in this trial, we were not allowed to give any pre-medication to prevent side effects such as the common side effects that happen with IVIG, which is headache, fever, nausea, and so on. We're not allowed to give ibuprofen, Tylenol, Benadryl, or any of those kind of drugs were not given. The reason behind that was we wanted to understand the true frequency of side effects and tolerability issue when we give IVIG in this patient population. And so we had a very high frequency of headache. 42% patients had headache, 20% patients had fever, many had nausea and vomiting, and then some had chills, musculoskeletal pain, blood pressure increase, and Coombs positivity. So quite a lot of tolerability issues, but the good news is that most of those issues were mild. 75% of those adverse events were mild, 23% were moderate, and only 3% were severe. But perhaps for me, even more important point that I tell my patients is the relation of those side effects. If you see on the other graph, the relation, the 92% of those side effects were infusion related. Only 8% were non-infusion related. Now, what does that mean, infusion related? Which means when the patient is reporting and suffering from those side effects is typically during and immediately after the infusion. So if you're giving monthly infusion, you could tell the patient that the 2 to 4 days are going to be tough because of the side effect, but then side effects will dwindle down and you will feel better. And that really helps the patient to understand the side effect profile of the patient, and they feel much better about getting IVIG when you tell them that. Now, what about serious adverse events? Now, there were some serious adverse events, including 6 events in 5 patients, which included PE, DVT, stroke, and TIA. So when these events happened early on in the study, we had a discussion with FDA, and this was decided that perhaps these events, which were unusual for us, are happening due to high rate of infusion of IVIG. As you know, IVIG is a very viscous drug, and perhaps it's causing thrombogenic effect on the top of dermatomyositis. Is already a thrombogenic disease, and we are adding a lot of IVIG very quickly, so perhaps it's causing thrombosis. So what we did is we decided to decrease the maximum rate of infusion. And when we decrease the maximum rate of infusion, the frequency of TEE significantly dropped down, as shown in the slide. So we don't recommend high rate of infusion, high rate of maximum rate of infusion. We recommend slow infusions in our patients. Now, when we looked at the patients who had TEE as compared to those who did not have TEE, what we found is an interesting observation that those who did not have TEE, on an average, they only have 0.6 risk factors for TEE per patient. But those who had TEE, on an average, they had 2 to 3 risk factors for thromboembolic events or TEE. And these are the risk factors given on your screen. So again, my appeal is to those doctors who are giving IVIG, if you have 2 to 3 risk factors as listed here, then please be cautious and decrease the rate of infusion as much as you can. If you are planning to give it over 2 days, give it over 4 days, and that will significantly help. But also if the patient has a recent history of DVT, PE, MI, or other significant thromboembolic events, then it's best to avoid IVIG if you could. The last part of the talk, I want to talk a little bit about the mechanism of action of IVIG. As you know, IVIG is used in many other diseases. I'm sure you do use IVIG in many diseases as well. The IVIG is known to have multiple different immune effects. And those immune effects are listed here, which include, inhibition of B cell function, complement scavenging, neutralization of the antibodies, competitive inhibition of the reticuloendothelial system, inhibition of TH17, those kind of saturation of protective FcNR receptors. But what we believe that perhaps the most common mechanism of action could be complement scavenging when we give IVIG in dermatomyositis, although many other factors could be playing a role. And what evidence do we have in saying that? To understand the evidence behind that, let's first review the pathology of dermatomyositis. As you may already know, that patients with, when you do muscle biopsies in dermatomyositis, what you see is something called perifascicular inflammation and atrophy. That means the inflammation is more around the muscle fascicle rather than in the muscle, not the endomysial or right in the center of the muscle. So that's the periphery is where there's a lot of inflammation, and the cells that are on the periphery atrophy. It also has a similar pattern of MHC1 upregulation. So you have a perifascicular pattern of MHC1 upregulation. But importantly, when you look at the cells that are dying, what you see is membrane attack complex in the muscle, and you also see significant capillary loss. And this was studied by Delakas et al. Several years ago. What they did is they looked at before IVIG and after IVIG muscle biopsies, and they saw that there's a disappearance of C3b and MAC in post-IVIG patients, suggesting IVIG cleared the complement in macrophage activation, membrane attack complex, that led to improvement in these patients with improvement in their strength. So this study finally led to FDA approval of dermatomyositis, FDA approval of IVIG in dermatomyositis with efficacy and safety proven in a phase 3 randomized controlled trial. So how has that changed my treatment algorithm in myositis? First of all, I've started to use IVIG upfront in certain patients. Those are patients who have severe dysphagia, patients who have severe disease, patients who have cancer, patient with pregnancy, patient who have increased risk of immune suppression, those who are, have recurrent infections and so on, or those who are currently suffering from chronic infections, those who are at risk with malignancy. These are the patient population that I would use IVIG up front, along with and without steroid and with and without methotrexate. The first line still remains methotrexate, but I would quickly add IVIG in the first line for sure if I'm not using it up front without steroid. The second line, again, we use IVIG more, and third line, we definitely use IVIG. So what has happened is we're still using IVIG. It just has moved up a ladder a little bit by 1 point that it can be used up front as a standalone treatment, especially you would use that if the patient steroids are contraindicated in a patient. And you definitely will use it as a first-line treatment along with methotrexate in patients with dermatomyositis. So in conclusion, IVIG is an efficacious, safe, and well-tolerated treatment for dermatomyositis. Safety profile with high doses. Remember, on dermatomyositis patient, we give high doses. Safety profile of even with high doses is consistent with commonly reported adverse events. It's been led to an approval of IVIG in US and Europe and other countries. Overall infusion reactions are mild and are infusion related, but keep in mind increased risk of thrombogenic event in the patients who have high risk for thromboembolic events to begin with. With that, I would like to thank you from Pittsburgh Myositis Center and happy to take any questions at this point.
Thank you so much, Dr. Aggarwal. That was an incredible presentation and a 2/3 response to IVIG. That's great.
Yeah.
So we're open for questions now. I will start off if that's okay, and then we'll open it to the audience. Just in terms of your trial, I was having a read through as well, and the 2022 paper, and presumably all patients were on other immunosuppressant medication as well. How did you account for that? I mean, yeah.
So first of all, when they were on other standard of care immune suppressive drug, they had to fail that. That means they had to be on that drug for 3 months and still have active disease. And the second thing is, during the trial, their dose was kept stable throughout the trial. So that's why we know the effect that we are seeing is not due to the standard of care immune suppression, because that was kept stable even 3 months before the trial and all the way during the trial.
Okay. And then we've got a question from Dr. Damsky, who asks, can you discuss autoantibody-based subtypes of dermatomyositis and whether or not there's correlation with the likelihood of response to IVIG?
So that's a great question. Actually, we actually looking at it very actively. The first look that we had, and this is a very preliminary analysis, we didn't see a striking difference in those patients who have positive autoantibodies versus not. Okay, so overall, we haven't seen that. But what we're doing further is asking a question: could a specific myositis, a specific antibody, have more response than others? For example, as you know, there are five or six most commonly reported myositis antibodies that are related to dermatomyositis, which include anti-synthetase or Jo-1, patients with MDA5, TIF1 gamma, MI2, and NXP2. These are the five most common dermatomyositis MSAs, or myositis-specific antibodies. So the question we are trying to ask is, okay, that's fine. Our antibody positivity versus negativity is no different, but could there be a higher response in patient with a certain specific antibody, such that, let's say, if the Jo-1 antibody always have a really like 90% response, whereas MI2 may have 30-40% response. So we're trying to dive deeper into it. In this year, we will hopefully finish that paper and get the results.
There's no preliminary data that you want to share with us?
That's what I shared with you. When we looked at antibody positivity versus negativity, there was no difference.
Fine. And then in terms of, if you have a patient who comes in and has dermatomyositis, in terms of malignancy screening for them, so like colonoscopies, PET scans, et cetera, do you do that? And if they're negative, then do you do it annually? Or, I mean, what's your process?
So there are three different subsets. So let me explain you. So what we're actually going to come out this year is a paper on international guidelines on screening and monitoring of patients for cancer in dermatomyositis. So look out for that paper, but I'll give you the results on that paper right now. Basically, we're going to divide them into three subsets. One is called low risk, second is intermediate risk, and third is high risk. So low risk is you don't do CT scans. You just do age-appropriate screening. For example, CBC, if they need colonoscopy, mammogram, pap smear, whatever is as per the local regional age-appropriate screening, which any patient should get. When it's an intermediate risk, you start with CT scans, and but intermediate risk baseline CT scan is enough. You don't repeat it every year for next 3 years. Okay? The high-risk patient is where you're going to do everything. Not only do you going to CT scan, you may actually have a choice to do a PET scan on those patients because they are high risk. And then if the year one doesn't give you the results or doesn't declare any cancer, you would repeat some of those tests in year 2 and year 3, up till year 3. So that's the algorithm we are coming out with to guide the community on how to do cancer screening in these patients. And the risk is based on three things: what antibody they have, what subset do they have? They have dermatomyositis or CADM or polymyositis. And third, what clinical features they have. Based on the three things, we can determine their risk profile.
That would be a very helpful guide for a lot of us, I think. So thank you for doing that. We've got another question from one of our attendees. They say, thank you for your great lecture. What could be done possibly during preparation of the IVIG to decrease the incidence of infusion-related adverse events? after the plateau of IVIG effect at 50 weeks, is there a maintenance dose? What could be a possible explanation of improved symptoms with exercise?
Sure. In terms of IVIG preparation, I think the main thing that you could do is limit the maximum rate of infusion. Okay. And so if you limit the maximum rate of infusion and you infuse it over longer time period, that's the best antidote to AEs and especially serious AEs like thromboembolic events. The second thing is give a pre-treatment to your patient with ibuprofen. I typically give ibuprofen starting from the night before the infusion to TID for the days of infusion and 1 or 2 days post infusion. And that really helps, along with a little bit of Benadryl and Tylenol. In terms of plateauing the effect of IVIG, I would say the IVIG start to plateau around 6 to 8 months. So even 50 weeks I think is a lot for me. And IVIG is associated with significant costs and shortage. So I evaluate my patient at 24 to 28 weeks. And if I see plateauing of the effect, I start to go to the maintenance dose or decrease their overall dose. So what I start is 2 grams per kilogram every 4 weeks or every month. But at somewhere between 6 to 8 months, what I want to do ideally is to decrease their dose to 1 gram per kilogram per month every month. And if they do better for next 6 months, I want to decrease it further to 1 gram per kilogram every other month. And if they continue to do well, then taper it off. So I would like to taper off their IVIG in about 15 to 18 months. But if I don't start at 6 months to start thinking about decreasing the dose or putting them on a maintenance dose, then I won't be able to achieve that.
Okay, and are you able to discuss your thoughts on subcutaneous IVIG or any important differences with?
So we haven't seen any clinical difference in sub-Q IVIG. What we have seen is preference differences and side effect differences. There are clearly a patient population who don't like IVIG and like sub-Q IG, and there's clearly patient population who hate sub-Q IG. In fact, I had a patient who had a panic attack giving sub-Q IG, and I have many patients who love sub-Q IG. So it's a patient preference, and the second thing is the side effects are different. You can get localized reactions, including rash and swelling, and which may be problematic for some patients, whereas you get different side effect profile when you give IVIG, such as headaches and stuff are less common when you give sub-Q IG. But in terms of efficacy, at least my clinical experiences, there is no difference. A formal study is yet to be done.
And in terms of like the clinical response that patients have, and obviously that guides your treatment and how you taper it, what is the creatine kinase the other kind of main thing that guides you, or?
Not really. Actually, that's another point I wanted to make. Creatine kinase is a very poor biomarker in dermatomyositis. It's a good, so the thing with creatine kinase is typically elevated when muscles are involved, but it's the level of elevation is not always proportionate to the level of weakness. And also the change in CK over time is also not proportionate or correlative of the change in the strength or the rash and other things. So it's a biomarker for sure. It helps in diagnosis, but it's a poor biomarker. I have many patients with normal CK levels with rip-roaring dermatomyositis with severe muscle weakness, severe muscle inflammation, but CK is completely normal. So do not go by CK, at least in dermatomyositis. For diagnosis, it will help, but not so much for following the treatment.
Interesting. Thank you. I'm going to ask one more question, and then unless we have any more from the audience, that might be our last one. So I know you mentioned that exercise is really important as well, and it has anti-inflammatory properties. Is there a specific kind of exercise regimen that you and your team are developing for these patients, or is it just general like?
Actually, there's a lot of studies done on exercise in dermatomyositis out of Sweden. They're the world expert on this topic. But they have shown, regardless of the type of exercise, but typically is the weight bearing exercises, typically it's more strength type of exercises that are very important in decreases actually improves the muscle strength and outcomes significantly. But what we recommend is even when the patient is bedridden, you start range of motion and stretching even on the bed. And if you continue the exercise the whole 1 year, which most patients don't get because of the insurance reasons, if they continue the exercise regimen through the supervised exercise, those patients' outcomes are far better those who didn't do the exercise. So it's clearly additional effect of exercise on our muscles.
Great. Thank you so much, Dr. Aggarwal, for your time. There aren't any other questions in the chat box yet, but feel free to give us any more pearls if you wish to pass them on.
I think one of the only pearl I think where I feel that a lot of people make mistake is one, when the patient only present with rash, a lot of dermatologists may not think of dermatomyositis. They may think of lupus and other common conditions. I think that can be a problem. Many of our patients present with rash alone as the main feature. Another common mistake I see is dermatologists don't believe in autoantibodies, so they don't order myositis panel that commonly, but those can be very helpful in not only confirming the diagnosis, but also in phenotyping the patients that, for example, anti-MDF5 patients may have a different outcome as compared to an anti-synthetase Jo1 positive patients. An MI2 patient might be very different. TIF1 gamma, you would be doing cancer screening quite often. So it has a lot of value. So I would still request dermatologists to look into it and think about ordering autoantibodies. And last pearl, I would say, we've already discussed this, use CK for your health, but don't completely rely on CK. CK is just like a small help to you, but your clinical impression is the most important.
Thank you so much, and also for that tip on the difference between the malar rash and lupus and dermatomyositis with the nasolabial fold. That was really handy. Actually, one last question: are we moving away from calling it Gottron's papules? Are we calling it something else now?
No, I haven't heard that, at least.
Fine. I think maybe there were rumors out there that we were moving away.
Yeah, I at least in my world, it hasn't changed yet. So
okay. Well, thank you so much for your time. I think we learned a lot, and oh, actually, something else has popped. Oh yeah, they've just said thank you so much for the lecture. Okay, so we will let you go, Dr. Aggarwal. Thank you.
Thank you very much for inviting. Take care. Bye.